Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Colin, and we are going over the brand new Prolonged Field Care Airway CPG. Hey Colin, how's it going?
Hey Dennis, how's it going? Going well.
Good. I think most people remember you from the Envenomation podcast that we did. So maybe just a very quick intro of yourself.
All right. Hey guys, my name's Colin. I'm a special operations medic in USASOC and one of the many people that worked hard to put this clinical practice guideline, or CPG, together. Thanks to the crew. If you guys are not familiar with the CPGs, every medic, instructor, and provider in the military should be aware of them. You can Google PFC CPG, and it'll come up as one of the first options. And we'll be discussing the airway one today and possibly how to implement it yourself, as well as if you're in a senior position into training in your unit. I personally like to print them off and keep them as copies in addition to the actual PDFs on my phone, just in case the phone fails. And at units, I like to use them to develop scenarios to train junior and non-medics. I use them in conjunction with medical references and books, because as soon as the book's released, it probably was put together like 2 years before it was released, a year or two. And so it can already be updated when it comes out. And then if something's wrong with it, it takes a longer time to be fixed and reprinted. Beauty of the CPGs, we can go in there and edit them and disseminate a little bit faster.
Yeah, that's absolutely true. You know, the benefit of the CPGs is it's kind of a living document. So as things change, we can be updated very rapidly. Now, most of the CPGs we have are bent around a certain pathology, you know, burns or crush or what have you. This is the only CPG that's all about an actual procedure. So I guess, you know, what was the drive or the push to have an airway CPG?
Well, airway is pretty important. I mean, we get so focused in March on M and bleeding control, but then a lot of medics, you'd get to A and R, and they're definitely not as confident as they are on bleeding control. And airway and respirations are interventions that you may have to address, like you said, across a myriad of pathologies that you're going to encounter. Right.
You know, I think a lot of guys, they also forget that, you know, it's a procedure, but just like, you know, any procedure, there's the pre, during, and an after, and we tend to forget about the after. Yes. When we place it, we make sure it's in the right spot, and then we kind of forget about it, not recognizing that there's a whole slew of steps that need to take place in order to maintain that airway. So I think laying them out in a coherent way, you know, allows us, like you mentioned, you know, organizing training or setting up training, allows us to organize the entire picture from beginning to end.
Yeah, definitely.
So in the CPG, there's a real emphasis on practice and proficiency training and sustainment. So, you know, in your perfect world, you know, what kind of sustainment training and would you do? You know, how much time would you emphasize on just airway management?
Well, first, it's an individual responsibility, like a lot of things. So you can't just expect the unit to be like, well, they didn't give me any training on this, so then they gave me this block, so that must mean that that's all I need to do. If you're familiar with the MCRIT podcast, Dr. Scott Weingarth that's behind it, he says himself he practices often using a Crike trainer that he made out of ventilator tubing. So if a doctor with far more years of training than us and more Crikes under his belt is consistently training under something, you know, every month or so with a little ventilator tubing, then that's something we need to be running through for our repetitions. How good would you be, for instance, at lifting or running or shooting if you practice that infrequently? So same thing with our surgical skills. We have that skill fade and we need to be practicing often. Even while deployed, I wouldn't rely on the fact that I did pre-deployment training a month or two before I left. I would do repetitions with some expired kits and leftover equipment that I had just to retain that muscle memory, kind of like you would do with dry firing your Glock in between your live ranges. Yeah. So definitely personal is the first part and most important. You got to, stay on it yourself. You can't expect the provider, your senior medic, to hold your hand and be like, hey, when's the last time you did this or did that? And you'd be like, oh, yeah, it's been a while. Do that yourself. Second, units have to implement it and support it. I know some commanders can think that once you pass SOCM, you're a magical wizard. You're always proficient and up to date, even if that was back in 2007. They don't understand skill fade and currency, especially not enough to lose you for days or weeks to some school that they don't really know anything about. So be adamant, persistent. You're going to be told no when it comes to medical training. Keep fighting the fight, keep being persistent, and keep going anyway. And then as the senior medics and providers in units, of course, your medics can be type A's and not want to drop their ego enough to admit that they're not proficient enough or that they need to train on something in some cases. So train and verify them anyway. You never know. They might think that they had it, or they might have 12 months ago, 24 months ago. And then you keep them, a little bit moment of humility there.
Right. And the last thing you want is to have that moment of humility when you're treating your teammate. I think people tend to, when you think about, oh, it's been a while since I did an airway, or it's been a while since I did an IV, we tend to kind of assume that we'll be good at it anyway. I think we need to kind of lean the opposite direction and kind of continually prove to ourselves that you can do something.
Yeah, it's airway is not a basic thing, even though people consider it to be. And even if it was, applying the airway isn't always the hardest part. Airway is an advanced procedure, but the hardest part would be making the decision to apply the airway or cut the skin. Even the easiest thing in our toolbox, like positioning, some people forget to do, and then a face mask seal, that's a surprisingly difficult basic, in quotes, intervention that you can easily mess up. I remember in SOCM, they had us doing sprints, and then, one guy lays on the ground, the other guy tries to get a seal, and you'll feel the air leaking out while you're in the oxygen-starved state, and you're trying to get your buddy to do a good seal on you. And it's something that novice medics and providers mess up alike. Now, that's just basic. If you look at complex, sure, we could teach a monkey or a child to crike or intubate, but it takes a clinician to know when to choose one over the other, or if the patient needs an airway or ventilation yet, as well as to what can go wrong and what to do next with that. Mm-hmm. And that's why in the CPG, besides just looking at indications for disrupted face or neck anatomy, we have some insufficient oxygenation or ventilation reasons. Because a lot of medics will see, it's easy to be like, oh, he's burned to his face with soot in his nose and mouth, or his jaw is hanging off. This guy needs a surgical airway. But the more difficult chances is when that swelling is a little bit more insidious with the burns or some other things, chest wall trauma, where the patient's lungs are failing, something's happening, and he needs an airway because he needs ventilation. And that can be a more difficult thing to do. And for senior medics and providers, I'd recommend putting those kinds of patients in some of your scenarios and not just giving them the easy way out of, oh, facial trauma, boom, I got my airway, that was easy. That way they have to watch the vital signs, watch the thing, and think, when do I take it and when do I not? Right.
And I think a lot also in those scenarios where it's not the airway isn't needed like emergently, like you mentioned with blast trauma or burns or whatever, where it's not blatantly obvious he needs an airway. People also forget about telemedicine. And if you are not in the need of an emergent airway, reach out and just ask your next level provider, ask somebody else who is not in that situation, what they think about the idea you're getting ready to do.
Yeah, it's definitely not easy. And then you add the austere environment, because there's situations where if I'm in hospital, I have enough supplies. If I make the call for airway, cool, I bought this patient's airway. In the austere, the PFC environment, I have to worry if I have the supplies to keep them down. Do I have 12 hours worth of medicine, 24 hours worth? Even if the patient needs an airway ventilation right now, am I able to sustain it? And that can be part of our decision-making process as well.
Yeah. Now, outside of, the simple airways, we talk a lot about crikes. And that's generally, when it comes to advanced airways, that's really the procedure we lean on. But in our course, either SOCM or what have you, we also teach, intubation. Is there any value in learning another technique for advanced airway placement?
Yeah, I think intubation definitely has its place. We have to remember that just because we are trained on something or even were proficient, that we may not be current as well. There are two schools of thought I find of medics, and there's those who don't want to intubate at all because they want to use the excuse that they have crikes because they're sexy. And then there are those that are like, hey, I think I can intubate because, I have like a dozen or so under my belt and they were all easy Malampati ones. And so if I did that 12 months ago, 24, I think I can rock it now with no sustainment training. And I think we could find a safe middle ground between the two for, hey, intubation has its place and there's some reasons where the patient needs an airway and we can do better than just cutting for everyone. And, but we need to also realize that to intubate, we may need some reps, and under some guided people who are a little bit better at us than them, so we can get a little bit better. There's also some studies showing we're not as good as crikes as we think we are, and that we are also unnecessarily criking patients that a supraglottic or intubation, would have handled and would have been better for these patients. So at minimum, it'd be good to have an iGel or other second generation supraglottic in our kit for some of those situations. If we can justify it, or if we can justify the weight, we're mounted, have a vehicle, and we're not carrying everything on our back. And if you want to be able to intubate, I'd recommend get the reps in through a local OR. They can be really supportive of us. If they aren't, then talk your way in. You should be able to talk your way into an American place, because we should be able to talk our way into foreign places. It's part of UW. So get your unit provider on board and go talk to them, especially if you have a military hospital like Womack nearby. Be humble and respectful, because I'm glad when I go to places and work in an ER or OR that the medics came before me, treated people really well, so I already had a good reputation going in. So don't ruin that if you're going to go in and get some of your reps. The other consideration I had is I used to be under some of that thought of, hey, I can just crike, that's probably what I'm going to have. And then go into Africa, they're like, hey, you have a local national, what are you going to do if you cut a hole in a local national's neck? And you don't have war authority in this country. It's not like Afghanistan. So if you hand this guy off to a mud hut that has a couple of doctors and a nurse in it, and he's got a hole in his neck, they're going to not know how to extubate him, how to care for it. And that's all because that's all you had in your kit was crikes. So that's another consideration. You have to understand the political implications of our actions in the SOC community. So medics can definitely do better than just crikes. And yeah.
Yeah, I mean, I think even at the very base level, we have to have a pace plan for everything. And I think most of our guys, when it comes to advanced airway, they say, I'll do a crike. Okay. What if it fails? What if you lose the landmarks? What if you lose your grip on his neck and now you can't find the hole anymore, but he still needs an airway? So having other ideas about how to get air from the outside inside is, it's just absolutely necessary. We have pace plans for everything. Why is it that, outside of a simple airway, our primary alternate and contingent is crike?
Yeah, I think at minimum, even shadow boxing through those scenarios with your medics could pay dividends. Sit down and go, if you have that one medic who he's got every crike on the mannequin, so he doesn't understand what happens if it fails because he hasn't failed yet, he probably hasn't thought through that. He's like, man, I got it. So ask him, hey, you're trying to crike and you just can't for the life of you. Having a bad day, the anatomy is a little bit weird, cannot find that membrane. The patient's desatting, what are some options? And like you said, hey, maybe consider ketamine and an iGel or even BVM face mask to keep the SATs up to buy you a little bit of time. And there's those other situations, such as if you have blunt trauma to the crike where that membrane is no longer going to be useful or efficient. Maybe we have to go a little bit lower with the trach. or if you have some shrapnel that peppers some of the vascularity in your neck and it swells up, big hematoma in the neck, and you just cannot palpate those landmarks, some things medics might have to think about. Instead of making a small 1-inch incision, do I just zipper them up with a big 3-inch incision and just go from there to find landmarks? Some of the situations, that they may encounter.
Right.
And we can induce that into training through talking through them, some of these situations. If you do cadavers, you could always consider adding trach afterwards. They know the differences. That way they don't get as aggressive. I know when I crike, I have that full cartilage ring around, so I don't have to worry as much about how aggressive I am with the cut through the membrane. But if you do that with the trach and it descends into the sternum because you completely cut that ring and it detached, then you'd have a bad day for sure. So things that they need to think about.
Yeah.
When you're doing some of these trainings like on cadavers or the realistic models, you can put fluid under that skin to where it becomes a little bit more difficult for them to palpate, so it's not as that blatantly easy field goal for them to put it through as well.
Right. I mean, a very simple scenario is pediatric. We keep our big 7.5 or 8 tubes in our kit. Well, you try and crike a 7-year-old child with an 8, you're going to be hurting. It's not going to go.
Yeah.
So you're going to have some other.
Definitely.
Yeah, you're gonna have to have some other technique when you're talking about real small peds.
Yeah, peds. There's a section in the CPG for peds and some of the considerations because they are different. So we put that in there because a lot of medics, if you mention peds to them, they're like, oh gosh, the look on their face, like, please no peds. Which, hey, maybe you need to throw like a pediatric role player or maybe a little infant dummy into some of your musculoskeletal trauma training so you get a little bit more comfortable with that. If you're not comfortable, that's what you need to be working on. But you also nailed it with tube size, because I noticed I'll go through some of my junior medics kits, and in their crike kits, they'll have an 8.0, and I'll be like, hey, what's the external diameter of that? And they'll be like 8.0 millimeters. I'm like, that's the internal diameter of the tube, so the external is probably add a couple millimeters, closer to like 10 to 11. And what's the average size of the crike membrane for an adult? And it's going to be around the same, and if they're, a large male. So if their crike membrane is only 7 millimeters and you're trying to get an 8.0 in there, it might be a bad day. So medics might want to consider doing your 6.0. That's what the experts are putting in for their crike kits. And it's a lot easier to hit a hole with a smaller tube rather than trying to jam something that might not fit in there.
Right.
You might have to switch it out later, of course, because you have those pulmonary toilet issues. It is hard long-term ventilation through a 6.0. Obviously, so that's a consideration later on, but first we need to get the airway in initially.
Right.
So just like you're saying for your kits, plan out what your loadout is, and in the back of the CPG, there are considerations for what you may bring or what you pack out or need.
Yep. I mean, and you can upgrade or downgrade an airway, as the situation, as the kind of the stress, the immediacy of the airway is kind of resolved and we've gotten things under control. If you started off with a real small airway, I mean, you can always upgrade it. You can get a bigger tube or even intubate if you need to. But just getting over that emergent situation, you can always change it later on once things are more controlled. Now, everyone's got a technique. I like scalpel finger bougie for a crike. Some people, they like doing whatever they like to do, right? Everybody's got a technique. What are the principles, though, that medics or providers need to take from the CPG?
I think first, just with a lot of things in medicine, don't do something just because you were taught to, or that's why we were always taught. It's definitely a dangerous phrase. So, hey, my instructor taught me. That's the way we've always done it. Oof. Know the why behind. That's what makes us clinicians, not technicians. And stay skeptical so you can update your information when new information is presented that challenges what you're currently thinking. It's dangerous to follow one thing blindly. There are definitely multiple solutions. And hey, if two experts are doing things 2 different ways and that both works, hey, that's medicine sometimes. Just don't be doing stuff that's either like wildly outdated, dangerous for your patients, or maybe trying some new stuff without adequate training and repetitions on it.
Yeah. I try and when I talk about airway with, whoever I'm teaching, I try to break it down. There's really two different types of airways. You have your emergent, where you're going in fast and things tend to be fairly sloppy, but you're just trying to get air from the outside inside, and we'll tidy things up afterwards. Then there's your kind of your delayed or your planned type airways, where you recognize this is going to happen. We can plan it out. We can optimize analgesia beforehand. We can come up with we have a very solid pace plan. Your mismade, get those things organized. We can do the procedure in a controlled, clean way. And then we have our aftercare, ready on standby. We have our suction, we have enough drugs, we have everything we need. So I think just thinking about organizing, not only the indications, contraindications of whatever procedure you're going to do, but just recognizing that not all airways have to happen immediately. Recognize there is a priority to march. And sometimes airway, even though it's the second letter, isn't really as important as, getting resuscitation going. He's got an open airway. He's still breathing. It's not great, but I think we need to start resuscitating first and worry about the swelling of the airway after.
I agree with that. And I think that's why in the new TCCC guidelines, they have in respirations and circulation both. In respiration, it says, hey, if you're doing finger thoracostomies on your patient and their blood pressure is still low, maybe that's not what they needed, move to resuscitation. And then vice versa. In resuscitation, it says, hey, if you're dropping, whole blood and stuff on your patient, their blood pressure is still low, consider that it's respirations, and back and forth, because those tie into each other.
Right. Now, whenever you get a group of medics and or doctors, and especially when you get both of them combined, there's always contention about any kind of practice guideline or some kind of, when you're writing some kind of doctrine, or this is how we all want this to be done. So when writing this airway CPG, what were the kind of the contentious areas?
Well, medicine, especially dealing with airway, is not a one-size-fits-all issue and solution. So you're going to have differences in preferences, experience, and capabilities. But we focus it by remembering our target demographic and giving some different solutions. Because you have medics just in different situations, so they're going to be in different ways. And ones with different solutions, like, hey, everyone's going to be in this situation. Everyone's going to have this equipment. And so we have to find multiple ways to finish the same thing. And that was definitely a difficult part is, hey, how much do we want to focus on intubation versus video laryngoscopy or, this or that? It's those are some of the friction points. Also, how do we organize it for it to be easy to read and format? We went with the mismade, which I'm sure you guys know if you're not new to the PFC website. Mismade is monitor, suction, machine, airway, IV, and drugs. And we settled on that because it's pretty easy to reference either when looking through the CPG or on real patients. I use this if I'm in an ER and about to get a patient. I go, okay, where is everything I need and what does this patient need? If I'm sitting there with a real sick patient in front of me and I'm like, what am I about to do for this procedure? It's a real easy checklist you can run through in your head, because you might run through and go, oh, wait, I have, my drugs are over here. Well, let me pre-draw it so that during the procedure, if something happens, my non-medic or my junior medic can go ahead and push that syringe a little bit easier, can do this. So as you walk through the clinical practice guidelines, the first part, machine, as you're going through your ABAG, grab your BVM with the PEEP valve. That is mandatory. So the bare minimum says BVM with PEEP. If you don't have a PEEP valve attached to your BVM, you're wrong. You don't want to ventilate a patient without PEEP for extended periods of time, especially because we're one of the only populations that's going to be bagging our patient on room air. So PEEP's mandatory on that. Also, know the limits of what you're going to have. A lot of people are like, hey, I have a Save 2, I have a ventilator. And I would try to think of the Save 2 as not a ventilator, but more so an electronic BVM, like an electronic hand that squeezes a BVM. It's really limited, and it's not a critical care ventilator, and it can't do a lot. It can tie you up. It can get your hands free from being tied up for a short period of time, but you need to know it's not one of the critical care ventilators, because what does the PEEP go up to? Only 10. So if you call telemedicine and you're like, hey, my PEEP only goes up to 10, they're going to say, well, okay, I can't help you anymore. But if you know your equipment, say, I could take him off of the ventilator, switch him to the BVM, and crank my PEEP valve up to 15 or 20, you can give the person on telemedicine more information, help your patient out more, and then know that. Also with the machine, from the senior instructors and provider standpoint, make sure your medics know the DOPE acronym. It's like tap, rack, bang, but for BVMs and ventilators if anything's going wrong. Because if there's a vent alarm, we don't want to just be ignoring that or taping over the little stereo speaker that emits the sound on our vent. There's a reason it's going off, and vents can be murder weapons in the wrong hands. So make sure that you train your medics on this adequately and know your limitations of the equipment. As far as suction, mandatory to have in some way. As soon as you pull that BVM out, go ahead and have some suction ready. Even if your patient doesn't have an airway in and they're critically ill, good to have an airway and suction on standby next to them. Improvising isn't always the best idea, so if you're going to improvise some stuff, try sucking up some little fluid with it and see how well it really works. And if you're going to intubate, if you're trained on that, it's in your repertoire, then I would look up the SALAD method, SALAD, it's a method to suction and form intubation pretty much simultaneously, so you can get a good view if your patient was vomiting, had a lot of blood in the airway, and you wanted to go that route. Next would be monitor. So EMA is great when paired with your SpO2. Gives us a lot of information for out in the field. Make sure to bring extra batteries, learn that one the hard way. And what we can do as senior medics and providers or units is either like induce failure into some of these, or ask them what they would do if there was a certain reading on either one. Because your medic may look at the SpO2 and be like, it's 82, and we're like, okay, what could we do different? And they may answer, I'll just change how much of the bag I'm squeezing or how often I'm squeezing up the SpO2 instead of changing the PEEP. So those are some considerations you may want to run your medics through, either shadow boxing or in training scenarios, so they know which value they're going to be changing with that. Same for the EMA, like, hey, what if your EMA said 72 right now? What should you be doing? Well, if you look down and it said 20, these are some things. That way they know their equipment, they know how to take care of their patients and guide them. Airway, just be prepared even if you don't think you're going to crack this patient, because you're like, hey, I've made the decision that I'm going to do face mask seal on this patient. I'm going to just do an iGel. I'm going to just intubate because he doesn't have burns to the face. He doesn't have his jaw shot off. I'm going to just do a regular airway, non-surgical. I would still have an awareness to prepare for a surgical procedure. It doesn't hurt or cost anything to go ahead and palpate that membrane and just in your mind go, hey, this is where I would have to go if everything went down. Have your pike it out and have it ready. Because there are times where people have hesitated on that, where they were just trying to intubate, missing, and the whole time the patient is just desatting. Which is definitely, if that happens in hospitals where they have a lot more support and a lot more oxygen, then it's definitely a worse situation when it's us by ourselves and we're playing all the roles and we just have room air. For airway, iGel is also a consideration. Use the NG tube, because the second generation supraglottics are going to have that port for the NG tube, a little bit safer to go ahead and decompress the stomach. If you're still using the King for some reason, consider the updated King, and that's got an NG tube port on it as well, the King LTSD or something like that. IV in Mismade, pretty self-explanatory, but is it patent? Do I want to go ahead and double check it in case I need meds halfway through a procedure, airway, or something like that? And then, then my one thing isn't patent, and where's my IO? Oh, it's here, or it's there, it's hidden, and Murphy's Law happens. So have everything out ready in case you need it. Should I get 2, or do I have time to do that if it's emergent? Don't get bent around the axle. Some medics I have to stick twice for going IO. If your patient's critical enough, let's go IO so you can get that access immediately if you need it. Don't get stuck. If the patient's getting an airway, chances are they're probably getting blood and multiple drips and a lot of other stuff anyway, so they might need that second or even a third line. You've seen those patients in ICUs. And drugs, I won't touch on too much because that's its own entirely different CPG and for a reason. But you have to know what you have and how long it can last, which changes if your patient's changes, such as transport, pain, and the like. So your 48 hours of pain meds can quickly become 24 rather quickly. And sure, you can reference doses. I hear when I teach a lot, medics are like, I'm going to look it up. I'm going to call telemedicine. And yes, that's always the right answer. Drop your ego and be like, yes, look up the doses. Be willing to call telemedicine. But on the same hand, you also you got to have some stuff memorized. There's going to be times where you just can't sit there and be flipping through a book and costing 30 to 60 seconds plus. I've even seen medics take 5 to 7 minutes looking up, calculating epidrips while the patient's blood pressure is just tanking. There's some things like tap rack bang where if you need it, you should probably need it now, and you shouldn't need to just sit down and phone a friend. You don't have the time. Some things we got to be able to do on the spot and know.
Right. Stuff like that. I think, just having your just quick reference cards, and you've done the math already. You've looked up the dosing, write that stuff down, have it laminated in a card in your drug box, just so you can have a quick reference. Because when the stress is on, that is not the time to be doing math. That's for certain. And even just finding the reference out of your TMAPs, get out of here. You're not going to find page 37, anytime quickly. So just have that stuff written on a 3x5 card and laminate it so you can have just a quick look and find it. But yeah, absolutely. Yep. You're going to have that stuff. Your final answer doesn't have to be written right then, but you're absolutely right. Some of that stuff you just have to just know and get it done. Know how to put it together and know how to administer it in a rapid fashion.
Yep. So that's one of the reasons we put a checklist in the CPG is because there's doctors who do this stuff all the time, way more frequently than we do, because sometimes as a medic you're wearing a bunch of different hats and you don't train as much as you want to. So we're usually not as proficient and up to date as they are, but they're still using checklist because, hey, human error happens even if it's your 10,000th rep doing something. So why not, instead of, flipping, I don't know which chapter this is in the book to look this up, you have something already printed on a little note card, like you said, or a checklist from the CPG that walks me through, hey, I just did a crike. What are the things on my post-crike checklist I need to look through as far as, what I need to do? So that we make sure we're not making small errors when we're tired, when we're hungry, when we're doing medical interventions on someone we know and something that we're not that comfortable with.
Cool. Hey, Colin, is there anything else that you'd like to add?
Yes. After you guys look through the CPG, Dr. Baines did a great airway podcast. He's an AT Delta turned ER doctor. So I check out that podcast because this one was mainly about the CPG, and his has a lot of great pearls about airway and ventilation stuff in and of itself. And then I would go on to the EMCrit website, and they have a whole section on surgical airways and videos of them being done and all this really cool information. It's a great podcast as well, and website. And especially thanks to those in the Prolonged Field Care Working Group and helped us put this CPG and all the others together.
All right. Hey, thank you, Colin.
Thank you.
That's it for today's podcast. Be sure to go to our website, www.prolongedfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.